Hello, everyone. Good morning, good afternoon, good evening. Welcome to Monday Mainstream VMR. Excited to be here co discussing with not only the backbone of CPS, but someone who is incredibly cool and so encouraging and inspiring. I remember that when I first turned my video on during the VMR, it was Youssef who actually reached out and said, hey, present cases and things like that. So I encourage each of you on the VMR and who's watching it on YouTube to come on and present more, with Mainstream Monday being an opportunity for you to present even simple cases and bread and butter ones. It's going to be fantastic, and please do present, and once you join the academy, you'll realize there's no other place like this. So yeah, excited to be here, and passing the mic to Youssef.
Yeah, Manaswini, thank you for your very kind words. We should name this VMR High Yield VMR because all the topics are so common that you're gonna see them so frequently. They're really high yield. And the person helping us with scribing today, Simi, do you want to say a word?
Hi, everyone. Thank you for joining and very excited for Sarah's case and discussion by Manaswini and Youssef.
Awesome. And Fahad is doing the teaching points. Fahad, did you want to say a word?
Hello everyone. So I'm going to be doing the teaching points here today. Let's hope I can extract most from two inspiring people.
Thank you, thank you. And Simi, whenever you want, we can get started. And Sarah, do you also want to say a word?
Sure. So just to preface my case, this is a common presentation that I have seen a lot. So bread and butter for me, but may not be for everybody. So it'll be an exciting opportunity to talk about workup and walk through things.
Awesome, we're excited. Whenever you want, we can get started.
All right. So our aliquot one is just a chief complaint of a 71-year-old female with acute loss of vision for 1 week.
Do I go first, Youssef? Okay. First of all, Sarah, thanks so much for presenting. Excited for your case. And so here we have a 71-year-old female with acute loss of vision. So I think it's important to see that she is tempo is queen in any presentation. So here we have an acute loss. So if I try and use everything I've learned on CPS, it would be to identify why is there a loss of vision. So is it something vascular, like something obstructing the retinal or the ophthalmic artery, or is it something pressure related, which could be compressing the optic nerve, and that would be associated with pain. And then it would perhaps be, I would also think about going through the optic pathway, and before that, so the retina, probably something in the retina or in the vitreous. So we still don't know what might be happening in this patient because it's acute, but since it's 1 week, I would not think about conditions like vitreous hemorrhage or retinal detachment and so on. But I would like to keep it broad and think about vascular, like pressure or perfusion or inflammation. So if it's vessel, then is it inside the vessel or on the vessel wall or outside the vessel? And if it's affecting the nerve and so on. And it could either be inside, like increased pressure in terms of a glaucoma perhaps, or if it's, and also to know her how vulnerable this patient is. Her underlying vulnerabilities might act up. And I would like to pass the mic to Youssef and know what he thinks.
Yeah, similar to you, I still don't know what the problem is. I really like how you described it as acute. It's 1 week, so that's helpful. It's not hyperacute, which hyperacute etiologies, typically we think of, like you're saying, like a vascular event. And then this patient may have had like a hyperacute event a week ago, and now we just have like a step down we're seeing of that. And then I'm still very early on thinking of, is this one eye or both eyes? And are we talking about nerve, or are we talking about like an eye ocular issue? And I think that will be really helpful once we know which eye is involved. Is it one eye or both eyes? And then if it's like painful, painless, is it progressive? And the tempo will be very, very helpful. So Sarah, can't wait to hear more.
Great thoughts, guys. For your Alcott 2, her HPI, 1 week ago, she experienced acute onset of painless, complete vision loss in her right eye. She noticed her vision was completely black in her right eye after waking up from a nap. She went to her local eye doctor, who then advised her to go to the ER. She did have a delay to our center because she ended up having to be moved from one center to another. So that maybe contributed to her 1 week ago presentation. Her ROS, she denied jaw pain, headache, double vision, or proximal muscle weakness, but admitted that she had some cough and shortness of breath. Her past medical history includes hypertension, COPD, heart failure with preserved ejection fraction with last EF of greater than 60%, coronary artery disease with a stent placed earlier in the year of presentation, hyperlipidemia, and ovarian cancer status post-surgical management and remission, as well as a mood disorder. Her medications, she takes metoprolol, aspirin, atorvastatin, and aripiprazole, and has no known autoimmune conditions in her family history, with a 80 pack year smoking history and current smoking use of 5 cigarettes per day and no allergies. So I guess with this all in mind, it'd be helpful to hear what you're thinking about.
Awesome. Manaswini, we hear that, like, we initially thought it was maybe like acute, and now we hear that it could be potentially hyperacute, but the presentation maybe was just like delayed, like we predicted. And we hear that it's unilateral. Now that you hear that, which of the etiologies do you think is like less likely? Like if we said, okay, brain, like occipital lobe, all the way to like by like nerves, or is it in the eye? Which ones do you think are like less likely, and which one are you like moving a little bit up?
Yeah, Youssef. So, like how neurology is, I'm like hoping this is a neuro case, but it like where the disease, why the disease, and what is the disease. So, when we think where it might be, definitely wouldn't be beyond the optic. It wouldn't be one side of the brain. It wouldn't be one side of each. Yeah, it wouldn't be since it's unilateral, it wouldn't, I'm sorry, it wouldn't be like something that affects both sides of the both eyes. So definitely not involving both lobes of the brain. And something that I would like to segue is the things that involve both sides of the brain would be like artery of Purkinje supplying the thalamus, or it's the brain stem, or like both the hemispheres involved. So I would rule out those and segue more into unilateral, probably optic nerve or optic, like the ophthalmic artery, and before it like retinal or ICA and so on. That's what I would think. And yeah, would like to hear your thoughts.
Yes, similar to you, I'm like thinking, first of all, it's like one eye. So could it be like in that eye, or in that nerve, or in that vessel? It's like putting that as a higher likelihood. And then we hear that it's painless. So which areas of the eye are actually like innervated for you to even feel any like pain? So if it was like anything like exterior, like if it was like keratitis or uveitis, that can be really painful. But just by the fact that it is painless, it makes you think that this is less likely to be like an exterior etiology. And I think the exam is going to be really helpful there. I think the biggest thing that's actually going to be helpful, in addition to like like looking at the eyes, doing like visual fields, is maybe like fundoscopy. And let's say we see like fundoscopic evidence of like arterial or venous like occlusion. I think that will be really helpful. And if we see like any retinal disease, that will be really helpful. I think that will like help us like go really quickly from like localizing to going into the differential diagnosis. And then in terms of past medical history, so how do we relate like ovarian cancer, heart failure to ocular etiologies? So a few ways. So one thing I learned recently is that pulmonary hypertension can cause retinal detachment just via the increased venous pressure. So if somebody has like COPD hypertension or heart failure, they're at risk for pulmonary hypertension, class 2, class 3, group 2, group 3 pulmonary hypertension. And that causes backflow of the venous drainage, and that can cause retinal detachment. And I learned that recently. That's one way. Another way is this like an embolic phenomenon. Like if they have HFpEF, they probably are at risk for AFib, so that can cause them at risk for embolization. Another way I can think of is if they have a malignancy, that they have like a recurrence and are now like hypercoagulable somehow, which we are not like currently apparent that I can think of. And then in general, I try to think early on about like ask about weight loss and consider like vitamin deficiencies, and because if you see any signs of that, you can have like a painless vision loss that's sometimes even bilateral, but here it's unilateral. Like B1 deficiency, for example, can cause like a painless vision loss. So I think the exam is going to be helpful, and not just my exam, but also like the ophthalmologist exam with a fundoscopy, or a very trained internist or neurologist who can like take a good look and see. In terms of, it's also helpful like we don't hear about headache, because if we were considering like ischemia to the nerve, so if we're considering that the patient suddenly developed like ischemia to that nerve, what causes ischemia? So you can consider like a vasculitis or like an arteritis. We hear that the review of systems is negative. That's unfortunately not sensitive enough. But I think if let's say we find an actual like nerve as an etiology, then we can consider working that up further. But let's say you're considering like giant cell arteritis, the only thing that has like a high likelihood ratio is like jaw claudication that has like a likelihood ratio of 4. But otherwise, almost all your history is not going to be very sensitive, unfortunately. Like almost no test is sensitive. So it's more like try to first localize the lesion. And then if we find that the etiology is in the nerve, then maybe we can like expand the differential further. But I think that's where I'm at. So Sarah, I can't wait to hear more.
Great discussion, y'all. So we'll move on to her physical exam. Her vitals were all within normal limits, except for heart rate. She was a little bit bradycardic at 55. Her general appearance, she was well developed, lying in bed, well nourished. Her lung exam, clear to auscultation, abdominal exam, and MSK, all grossly normal. Neurologic exam, she was oriented, like peripheral neurology exam, totally normal. She did have a relative afferent pupillary deficit, but like all of her ocular movements were intact and there were no issues with respect to that. I will give you the ophthalmology exam because ophtho was pretty immediately consulted here. So there were a lot of terms here, but just to summarize that exam, she was shown to have right-sided pallid disc edema, peripapular retinal whitening, extending into the macula, and then inner retinal edema. And they had some concern for GCA, but they felt like it wasn't necessarily like diagnostic. So felt like that they should start on prednisone and then also talk to rheumatology to kind of figure out what next steps might be with respect to that. So I guess I'm interested here with a kind of non-diagnostic optho exam and potential next steps for GCA being pretty invasive. What are your thoughts for what you would have done here?
So I loved Youssef's discussion before this, and the data you presented, Sarah. So in this case, her vitals are stable, so her hypertension is well controlled. I wouldn't think about a hypertensive state as of now. And we see a pale disc, which might indicate a hypertensive state, but I'm still worried about the vessel involvement. And then we see RAPD. From what I've learned, we could perhaps rule out infections, send a bundle like RPR, HIV, and so on, just to get that out of the way. And I would, since the ophthalmologists themselves are saying that there might be greatest concern for GCA, and how you mentioned what we do for GCA, from what I've learned, I think it's so important to not wait to treat GCA. And anyone who's more than 50 with headache or symptoms of acute onset vision loss, I think the first thing we need to think of is GCA, to make sure they don't have consequences of it. But she's already experiencing the vision loss. So I'm really concerned for her, and I think that we know that we do a biopsy for GCA, and ESR is super elevated. But again, even biopsy wouldn't be confirmatory, so I wouldn't want to do a biopsy before we start steroids, and I'm glad that they did, because GCA might be so spread out that the biopsy might not find it. I would like to pass the mic to Youssef to hear his thoughts.
Yeah, so this is a very niche topic, very specialized, and there have been major updates the last few years. So let's start with what is giant cell arteritis. So it's a vasculitis of the large vessels, and whenever you think of large vessel vasculitis, the big two you think of are giant cell arteritis and Takayasu arteritis, and these can affect the blood vessels of the brain, but even the aorta, and then vessels in the abdomen as well. And you differentiate between the two depending on the age of presentation, and that's the biggest qualifier. Takayasu you think of younger than 50, while GCA older than 50, but they're largely very, very similar. So how do we diagnose GCA? So in the past, like you said, biopsy was gold standard, but now there's other ways that can clue you in. So one way to do it is to do a ultrasound with Doppler, and that's very institution dependent. So you actually depends on the operator who can get really good at identifying GCA on the Doppler. And if your institution has or does not have that, it will depend on how quickly you can get it done. So if you're in a tertiary specialized center, you can actually, there are centers that are specialized in diagnosing GCA on ultrasound Doppler, and it's really sensitive. So that's one way to do it. The other way to do it is to get a PET scan, actually. So you can do a PET scan and see which vessels light up in your body, and that can clue you in. Even MRI and CTA have also been used to get that diagnosis as well. So in addition to imaging, we can also do history and exam, right? So we can look for signs of polymyalgia rheumatica. So we can ask about, because they are associated with each other. So we can see if the patient has been having stiffness in their joints in the morning, for example, which would clue us in into them having polymyalgia rheumatica. And then we can ask about all the symptoms of GCA, which again, none of which are sensitive. And the only one that has a high likelihood ratio is jaw claudication. But then otherwise, none of your tests are going to be sensitive. And then the question of why don't we just do a trial of steroids? You can potentially, and you can potentially do that. It just has to time it with the specialist and see when can you get the imaging done, as opposed to doing a trial of treatment and seeing where this ends up. And then lastly, the feared complication of GCA is ischemia to the retina, which it sounds like we're probably seeing here. We're seeing retinal edema, it sounds like. which could be a sign of ischemia. So if you're worried about that, like imagine the blood vessel going into the brain and then that part not supplying the blood vessel into the eye, and that can cause ischemia of the retina. And that's why it can get swollen. And this is actually a question on, I don't know if it was step 2 or the boards, but one of them about like a complication of GCA, which is like retinal ischemia. So Sarah, can't wait to learn from you.
Okay, great. So we'll move on to just some labs. Her CBC was just a microcytic or a normocytic anemia, but otherwise normal. Chemistry, pretty unremarkable across the board. And then had an A1C of 6.1. She did have an elevated ESR from the outside hospital at 72 with the upper limit of normal for her age of 40.5. But once she presented at our hospital, it was normal, though she had been on steroids when we collected that second ESR, and her CRP was never elevated. Rheumatology was then, talked to at this point, and they felt that her GCA ROS was negative across the board, and had little concern for GCA after their exam, but recommended continuing steroids empirically until getting a temporal artery biopsy, as well as an MRI brain and orbits, and further examination for embolic or intracranial causes of acute loss of vision. So after their evaluation, she ended up getting a TTE with bubble study that was pertinent for having mitral annular calcification, and then mitral regurg. And then in limited view frames, there was a gelatinous mass on the posterior leaflet of the mitral valve. And we'll stop there, but they recommended getting a TEE for further evaluation.
Youssef, you want to go or you want me to go?
Yeah, if you're just like, how are you linking the heart to the eye, or how do you think they're related or could be?
Yeah, the first thing that came to my mind when Sarah said gelatinous is perhaps something like a myxoma or basically an embolus to the retinal artery is what my instinct thought was. So that's what I think, Youssef. What about you?
Yeah, that's what I was thinking as well. Is like we're suspecting could this be like an embolic phenomena into the eye? And we said earlier, like and the eye you can consider just like a stroke. Like if it's embolic, where is the embolus coming from? It's really hard to know if somebody has like a lesion, if this lesion is contributing to their embolization. So let's say you find a PFO alone, like 1 in 4 people have PFO. So it's really hard to tell if that alone can cause embolization. A lot of times what you do is you do like a bubble study, and then you can see if there's like crossing across the sides, and then that can help you know. The other thing is like if you find a mass, like in this case. So in this case, we see a possible like mitral leaflet mass, and the big thing I think of. I think I learned this from Robbie, but I don't know which. I think very long time ago. But the acronym for cardiac lesions is PCCC, which is like pus, cancer, calcium, clot. So pus you consider like endocarditis. This is like an infection. Calcium and like severe like hypercalcemia. Clot is like an antiphospholipid syndrome where you can get like a thrombus there, or any ultra hypercoagulable state, like a disseminated cancer, for example. And then the cancer is it could be like a primary cardiac tumor, or it could be like another cancer that's causing a lesion there. So the TEE is going to be really helpful. I think once you get like a better picture, that would be good. In terms of like calcium, you just look at the serum and see if there's like any signs of hypercalcemia. In terms of infection, like infectious endocarditis, a lot of times you do end up getting like blood cultures early on. And then in terms of like culture negative endocarditis, so you usually ask about exposures, so specific exposures. So in culture negative endocarditis, you get like the main etiologies are Brucella, Bartonella, Coxiella. So you can see if this patient has been living with like 6 cats, or like if they've been like working with cattle and see if they have like risk factors for it. And based on that, you can review like fevers and history of like infection. And then I think that's where I would start. I think sometimes the imaging itself can be helpful. So the TEE, the person doing the TEE can describe the lesion further and tell you what it looks like. And then it's hard to tell just from looking at it if it's metabolically active. Sometimes they do like a PET scan and see if it's metabolically active. And then this is where we end up in a hard spot. It's like, does this patient have GCA? Do they not have GCA? Again, like no history test rules out GCA, which is one of those like diagnoses. So you just want to see if there's an alternative diagnosis that can explain it versus doing the biopsy anyway or pursuing both. And I think this is where you also have like multidisciplinary care plan and see if the steroids help, because that will also be like the test of treatment will also tell us some more information. So Sarah, teach us.
All right, this is our like second to last aliquot. So this will be information, and then the next one gives the kind of diagnosis and in final resolution. She got an MRI, brain and orbits with no acute intracranial abnormalities or vessel hyperintensity. However, there was a 7 mm avidly enhancing lesion with T2 hyperintense signal in the right intraconal space near the orbital apex. The differential that was given here was orbital cavernous venous malformation and less likely venous varix. She got a carotid ultrasound that was normal across the board with less than 50% stenosis of bilateral carotid arteries. Her TEE result had pedunculated area in the mitral valve that was drumstick-like in shape, and the tip was mobile, favored to either be a vegetation of either vegetation or part of the calcification of her mitral annulus, and they favored it to have embolic potential. And recommended kind of presumptive treatment of an embolic thing that had happened. So blood cultures were drawn negative. She got a quantiferon because we were doing steroids, which was negative, and HBV and HCV testing were both negative as well. And I will say that she did end up getting a temporal artery biopsy that was negative for active inflammation. But she was also started on heparin because of this kind of vegetation and concern that there was like a clot of some kind. But she was also continued on prednisone. So what are your thoughts before I give you the final resolution here?
Youssef, I'm here to learn from you.
No, yeah, I think it's a really hard case. I think I'm not sure what to make of the cavernous sinus lesion. Like I don't know if this is like looks like an AV malformation, because that alone can change like the pressure of the eye. So that would be like a question mark for me. So I would like ask the specialist, like, do you think this could be like a cavernous sinus AV malformation? Because that alone can cause that. So that would be my question for the specialist. And then in terms of like cardiac lesions. So what do you do once you see like a pedunculated lesion? You're like, oh, is this endocarditis? Is this not endocarditis? Is this a clot? A lot of times it's just based on history. You can do a PET scan sometimes that can tell you if it's like avid or not. And then a lot of times you end up doing all of the things, just like sounds like what's happening here, because you're not like 100% sure. So you start like an anticoagulant to prevent thrombosis, and then you talk to ID and see if what they would recommend. And they can either consider further workup of like culture negative endocarditis, or sometimes just like letting it go, or sometimes even empirically treating, depending if the patient has like risk factors. I think it's reasonable to assume that this like whatever is on the heart caused the thrombosis, right? So you're probably going to do anticoagulation. You're probably going to say this is probably not GCA, and then at some point stop the steroids, and then talk to ID and see if we can get like a PET scan just to see if there's any infectious component to it. And then we would talk to the cardiothoracic surgeons to see if there's any like intervention that can be done in the future versus like an advanced cardiologist. So Sarah, a very hard case, multidisciplinary. I imagine you were talking to like 10 specialists at this point.
Yeah, I'm sorry for the maybe not mainstream Mondayness of it, but I guess the mainstream part of this is that really, they didn't know what was going on. They were just doing everything, kind of presumptive treatment of both GCA and um, like CRAO. At the end of this presentation, she had been in the hospital for 7 days. Her vision had improved slightly in the right eye. She'd gotten a temporal artery biopsy that was non-conclusive, and her vision had improved somewhat in that right eye. And care teams kind of agreed that her presentation wasn't perfectly characteristic of giant cell arteritis, but figured that she had improved during this time, although there was still some disagreement as to whether this was GCA or non-arteritic ischemic NAION. And this is, I think, where I'll just leave it, that the original person that had sent her to the emergency room thought that it was NAION. And it's kind of like, I think that if that were the original diagnosis, then she may not have gotten this temporal artery biopsy. And she actually ended up with like a hematoma because she was on heparin and had had this biopsy. So I guess from your perspective, how much weight do you keep in like the first diagnosis that somebody gets versus um, information that you might collect along the way from things like a fundoscopy exam or whatnot, especially in this type of diagnosis?
I don't know. I think that's really hard. I think you just have to ask like the specialist. I mean, like, oh, how does like steroids impact the impact of fundoscopy? And I don't think I have like one. I don't think there is an answer. I think it's more like very niche and depends on like what area you're thinking of. And it can be hard whenever you get like a diagnosis ahead of time because that will force you to like anchor to that diagnosis. But this is how medicine goes, I think.
Sarah, what a wonderful case and beautiful journey from the first aliquot to the last. And like again, what I've learned on CPS is diagnosis is something that is human made, and we try to best identify what is going on. But as long as the patient improves and is doing fine, and like Youssef said, it's the beauty of medicine that we might not know what's happening, and we treat as much as we can, and that's what I think. And the differentials are so wide in this case, like you mentioned, GCA or NAION. Have to read up more on this, but yeah, thank you so much, and thank you so much, Youssef, for this opportunity. I really enjoyed it.
Yeah, and Sarah, what did the team make of the cardiac lesion, or what was the conclusion there?
Yeah, the conclusion there, we went and talked to like the reading room at that point, and they kind of felt like it just was calcification of the mitral annulus, and it was probably chronic, maybe embolic potential, but like given that it was probably chronic, they actually felt like it wasn't necessarily contributing to her presentation. Um, yeah, but there was definitely a lot of back and forth between like different radiologists and different reading room individuals.
Yeah, it can be really, really hard because like you once you do like imaging and then you find like abnormality, it's really hard to say if this abnormality necessarily relates to whatever you see, especially if there's like other potential like confounding etiologies. So, and this is how like real life medicine happens that you're saying.
This is the bread and butter
Yeah,
or the mainstreamness.
yeah. Thank you so much. Simi, can't wait to learn from you. Sorry, I mean Fahad.
So we had a wonderful discussion here. I'm just gonna summarize the teaching point. So the patient presented with chief complaints of acute, and her discussants emphasized that tempo is important in this case. So vision loss can range from anywhere starting from the eye up until the visual cortex. But in this case, as the tempo is hyperacute, it is most likely to be vessels. And it can be a lesion inside the vessel, outside the vessel, or on the vessel wall itself. And other differentials that can be considered are pressure-related changes like glaucoma, and it is also good to have retinal and vitreous involvement in the myths as well. Now, this presentation was hyperacute and unilateral. Now, what does that point to? It points to the fact that the vessel is most likely involved in this case, and the painless mean gives us the idea that it is less likely to be an exterior etiology such as uveitis and so on. And the key investigation to be done in this case would be a fundoscopy, which will make us reach the diagnosis at a faster rate. Now, Youssef emphasized on some of the systemic diseases which can lead to vision loss. One key example was pulmonary artery hypertension, which can cause retinal detachment. It can also happen in case of embolic phenomenon due to various different causes. It can occur because of malignancy, which causes hypercoagulable states as well. Now, ischemia to the nerve can present in ischemia to the nerve can present in one such way, and the most relevant differential in that case is giant cell arteritis. But in this case, there was no systemic evidence. Now, one additional point I would like to add is related to RAPD, that is related to afferent pupillary defect. Actually, the pupillary pathway and the visual pathway follows the same until the optic chiasma. So when a patient has RAPD, it says against cortical involvement and more points towards a lesion from the retina to the optic chiasma. Then we also emphasized a bit on giant cell arteritis, which is a large vessel vasculitis. It has very similar presentation to Takayasu, but a way to differentiate is usually Takayasu presents less than 50 years of age, while GCA presents more than 50 years of age. Now, an old teaching was that the gold standard for diagnosis is temporal artery biopsy, but now we have various other ways to diagnose it before temporal artery biopsy, and some of them are an ultrasound with Doppler. PET scan can be done to see which vessel lights up, and an MRI or CT angiography is also useful in this case. Now, if we suspect a case of GCA, we have to look for signs of polymyalgia rheumatica. Out of all the external symptoms and signs, jaw claudication has most sensitive evidence for GCA. And if there is concern for GCA, we don't have. It's better not to wait to treat and start steroids empirically, because the risk of vision loss is high, and this is a reversible cause. Now, the biggest concern with respect to GCA is ischemia to the retina. And finally, we touched upon the lesion in the valves, because the patient had some kind of lesion in the valves on echo. Youssef emphasized that it can be thought of as a mnemonic PCCC, in which it stands for pus, calcium, clots, mostly due to hypercoagulable states, and cancer. And we can differentiate it with history or with imaging. And if it is suggestive of clots, it is better to start anticoagulants empirically here as well. And that is the case.
All right. Thank you so much, Fahad. And hope you all have a wonderful day, and hope you submit your cases. We can't wait to learn from you all. Have a wonderful day.